So yes, I'm Kylie. I'm a consultant midwife at St Mary's in Manchester, and I'm going to spend a little bit of time today talking to you about my kind of journey to the role that I have, and then the rest of the talk a bit about some of the work that myself, along with lots of other colleagues, have been doing. Um, Mainly focused on research around reducing inequalities in maternity outcomes and experiences. So this is my kind of little slide about my life and my journey, I suppose. Um, and it looks all very nice in a straight line, and I've got another slide to show that actually it isn't like that really, and it generally isn't like that for most people. But in terms of my clinical career, I did a degree in chemistry and then a degree in midwifery, and you'll probably tell by my accent that that wasn't in the UK, that was in New Zealand. And then I worked as an independent midwife in New Zealand for about 4.5 years, which was amazing, really. In New Zealand, you can have an independent midwife, which is free. It's funded by the government. So I caseloaded about 50 women a year, had about 10 to 15% home birth rate, saw women all through the pregnancy, and then up to 6 weeks after the birth. Really amazing time and a real foundation for my career and passion for physiological birth and kind of autonomous midwifery practice. I then moved to the UK for a working holiday. I had a 3-year visa, um, and I'm still here. I met my still now husband in the year after I arrived. And so I've stayed here. I worked then at St Thomas's in London for 10 years on their low risk alongside birthing centre, and then on their consultant led unit, and then leading a team that caseloaded women who were higher risk. And had a couple of children along the way. That little first one there is about to go to university on Saturday, which I can't quite believe looking at that photo of him sitting there. And in 2012, we moved up to Manchester, and I've been working at St Mary's ever since as a coordinator on the consultant-led unit, and now as a consultant midwife. And in terms of my academic kind of work, when I moved, had been in London for a few years, I did an MSc in advanced midwifery practice. So that was with Professor Jane Sandel, who many of you will know if you're midwives, very well known midwifery professor and academic. And she really kind of got my interest going in research, and said to me at the end of the masters, "Oh, why don't you think about doing a PhD?" And I was like, no, I'm not going to do that. I'm a clinical midwife. But I did a small research secondment with her and a team that was doing some ethnographic work. So we went into another maternity unit and just kind of watched what was going on. And we were looking at meows scoring and escalation. And that was really the first time that I was involved with an actual piece of research, and I thought, this is amazing. I love it. Was involved right from the beginning to the end, and then the kind of write-up and publication of that piece of work, and thought, actually, I might want to be more involved in this side of things as a midwife. And also during that time, I applied for and got one of the 2 midwifery places on the NICE Intrapartum Guideline Committee. So that was a committee that sat for 3 years, looking at any new evidence that was available around care of women in labour at low risk of complications. And there was a lot of new evidence, and that's why the committee sat for such a long time. And again, that was exposed me to a huge amount of research, looking how that's critically appraised and how that is then becomes clinical guidelines. And again, I thought, yeah, I really want to be involved in research. And so I had a small pump priming grant from MFT, which bought out a little bit of my time to then work up a PhD fellowship application, which took about a year. And I applied for that and was successful and did a full-time PhD, which I finished in 2019. So there's a few influential people on this slide. Jane Sandel, obviously, my supervisors, Tina Lavender and Tracy Mills, but also within the trust, Cheryl Lenny and Kathy Murphy. Cheryl Lenny was our chief nurse, who very much has driven the kind of pathway that we have now for consultant nurses and midwives, that they really are clinical academic roles, and people in those roles should be working towards or have a PhD, and that really was driven by Cheryl. And Kathy Murphy, who's our now Director of Nursing and Midwifery, was very supportive of that as well. So as I said, that looks like a straight line, but it's definitely not a straight line, is it? There's lots of things that happen along the way. Sometimes you're treading water, sometimes you feel like you're going backwards, sometimes you really whiz forwards. And that's okay. I think that it's things happen in people's lives. I feel like I've done my PhD quite late in my career, but I still have quite a long time left in my career. So you know, there's no time is a bad time to be thinking about getting some academic qualifications. I just thought I'd try and put down on one slide what my role kind of looks like now, and it's a busy slide because it is a pretty busy role, but along the bottom are the kind of 4 pillars of consultant nurse or midwifery, around expert, generally being an expert in clinical practice, having a leadership and management to that, education and research. So that's kind of all along the bottom. On the left is my sort of clinical focus, if you like, which is pretty broad, but focused on midwifery-led care and pathways, continuity of care, support our fairly new dedicated home birth team. And we've got a midwifery-led birth after cesarean pathway, which I also lead, which we're trying to get embedded into the other 2 sites. So we have 3 sites at the trust that I work at. We have a very big birth debriefing and birth planning service across the 3 sites. So I lead on that, and I mostly do birth planning for women who want care outside of guidance. I've recently developed some personalised care and support planning and trauma-informed care training that we're rolling out to all of our midwives within the organisation. And I do quite a bit of wider strategic work with our local maternity and newborn service. One of the biggest pieces of work was leading on embedding intelligent intermittent auscultation across all of our 9 providers within the system. And that's obviously not all I do, but the main focus of my clinical work. And I also support our public health matron and some amazing work she does around prevention and cultural safety and ethnic minority engagement midwife, who's been in our trust for a couple of years. On the right is kind of the research activity. So research that I'm involved in, that I'm leading on, that I might be a co-applicant on, capacity building within the organisation and supporting other staff and midwives who are interested in developing their careers in research, and do some teaching at the universities and mentoring and supervising. And so the other smaller blue ones are, I'm really lucky to have a Band 7 midwifery research fellow who's employed by the trust, who works very closely with me, Bethan. So we do lots of work together. And then I supervise a couple of PhD students and support other midwives to apply. There's 2 midwives that have recently applied for fellowships. Meg, who I think is on the call, has just got a pre-doctoral fellowship, and Bethan, who's the Band 7 Research Fellow, has just applied for a doctoral application. And there's some other midwives around with pre-doctoral fellowships as well. So we feels like we're building a little bit of an academic midwifery team and group, which is really great. And in the middle, I suppose, are where there's a huge crossover in the clinical academic role that I have around the last few years research that's been focused on equity and reducing inequalities, learning a lot about that through supporting our cultural safety midwife, and the research that we've done. A focus on all of this around advocacy for women and increasing their experiences, and hearing women's and families' voices, and that really is central to all of the work that I do in this role, in both a clinical sense and an academic sense, is truly making sure that we're listening to women and birthing people and their families, and making a difference to the care that they receive. So in terms of, it's 6 years now since I've completed my PhD, but I thought this slide comes from quite an old talk that I'd given, but I think this still holds true, and some reflections on doing a PhD, that if you're thinking about doing it, then any time in your career is a good time. I don't think you're ever too young or too experienced, and probably not too old to do it. The NIHR fellowship routes, and they're not the only way of doing this, but they are an absolutely amazing way to get funding to do a PhD, and all of the training and all of the fees. So there's huge benefits in applying for those and getting one. They are really competitive, but there's a lot of support out there for people to apply and hopefully be successful in that. There are lots of other routes and other funding around, however, but if you are applying for one of those, then those applications do take a long time to get right and to work up, and at least a year is needed to get them. And that's not a year full time, of your whole life, but working on it kind of fairly regularly for a good amount of time to get those right. The right supervision is really crucial, and really your supervisors need to be involved from the beginning of that application, to guide you and support you and get that right. Small secondments, getting different bits of research experience are beneficial, and publications definitely. I think potentially there's a bit more of a focus on publications, and because they're becoming very competitive, then the kind of standard is going up. So if you can get 1 or 2 publications under your belt, that's great. Doesn't have to be as a first author, but getting your name on something definitely does help. I think the difference between an MSc and an MRes is important to recognise if you've done a master's, and I didn't understand that when I kind of was doing that if you want a career in research and you want to go on and do a PhD, then doing a master's of research is hugely beneficial. It doesn't mean that you can't do a PhD without one, and I didn't have one. I had a basic MSc, but a master's in clinical research is a really good stepping stone. Choosing your host institution is important. That's if you are kind of going down the fellowship route. I made a bit of a controversial decision. It probably isn't now, but it was then, to keep my host institution as the trust, because I wanted to stay within the trust when I'd finished the PhD. So that was what I did. A lot of people kind of a while ago had the university as the host institution and were kind of seconded out, and I think that has changed a little bit now. Think about your long-term career goal. Where is it that you want to be? I knew that I wanted to be a consultant midwife, and I knew that doing a PhD was also going to be really helpful in that role. And there's a massive amount of help out there from people like the Nursing and Midwifery Incubator, although that has stopped, but there's still a lot of resources around that were developed from that. The Research Support Service, universities, obviously Catalys for us in Manchester is provide a huge amount of support for people that are thinking about a career in research. So they were just a few thoughts in terms of what I did in my PhD. When I was on the NICE intrapartum committee, we looked at the evidence around wirelessly monitoring the fetal heart in labour. And there was some evidence, but it was pretty old and not particularly good. And I was, really passionate about ensuring that women who did need to have their babies continuously monitored in labour, and those are women who tend to have pregnancies that might have they might have an underlying medical condition like diabetes or hypertension. Lots of reasons that we recommend continuous monitoring. I was really passionate about women being able to be as mobile as they could, because we know the benefits of that in labour, of being able to use the water, and looking at the benefits of that for women in labour whose babies did need to be monitored continuously. So that's what I decided to do my PhD in. And it was a mixed methods piece of work, looking at some clinical outcomes, of clinical outcomes of women that had this particular wireless type of monitoring compared to women that had conventional wired monitoring. And then some qualitative work interviewing midwives and interviewing women who'd had wireless monitoring. I'm just going to have a drink, sorry. So that was a 3-year piece of work. Really good grounding in skills and systematic reviewing, doing mixed methods, analysing qualitative and quantitative data. And the end result of that was that, not surprisingly, women really liked it. They reported that they felt more normal in labour in terms of being able to do normal things like move around, go to the loo, get stuff from their bag. And in terms of the quantitative work, we did find that women that had wireless monitoring for the majority of their labour reported more control and satisfaction around their labour and birth. So there was a few, one main publication from that, and some other bits of work I was involved in with other people. So that finished, and I started the consultant midwife job kind of at the end of that. And things kind of then took a bit of a tangent. I'm still really passionate about this, and we've got more wireless fetal monitoring within our organisation, and I think lots of trusts have it now, and I hope that evidence that I had generated helps people kind of perhaps argue for getting more of it within their organisations. But I started my consultant midwife job in 2019 at the end of that year, and obviously COVID was the very beginning of the next year, and I hadn't been in the role very long when COVID hit, and that was upended all of our worlds in both a professional and personal sense, didn't it? And around this time, really, there was becoming more and more apparent of the stark differences in outcomes for women from Black, Asian and minority ethnic groups within the UK. And we saw this play out in COVID, the really big differences in outcomes for people from different ethnic groups. And there were reports that were starting to come out as well around women's experiences. So Birthrights published this one on the left called Systemic Racism, Not Broken Bodies. There was a report by a Muslim women's group, Maternity Experiences of Muslim Women, on the right. And the 5 times more campaign kind of started around this time as well, and that came from the confidential inquiry report, which is the bigger picture there. That this is the most recent one, but the one 2 years earlier to that showed that Black women were 5 times more likely to die in the perinatal period. The most recent report there shows that Black women are 3 times more likely to die, and Asian women are 2 times more likely to die than their white counterparts. Also, if you live in deprived areas, you're more likely to die. And so there was a lot of this kind of work coming out, very difficult reports to read around women's experiences, and obviously the clinical outcomes are very hard to kind of look at and understand as well. So I was very new in the role, and I was working with another midwife called Kim, who was in this midwifery-led research role, and we thought about lots of different things. And what we decided to do was do a piece of work focused on Manchester, on what were Manchester women's experiences of their maternity care. This slide is one of the most arresting slides I think I've seen, and I say it every time that I present it, but this is around ethnic inequalities and stillbirth rates. It's a little bit old, but it's still, those inequalities still exist. So from left to right, this is women living in the least deprived areas to the most deprived areas. And then from top to bottom is different ethnicities. So you can see that if you're a Black African woman living in one of the most deprived areas, your stillbirth rate is about 4.5 times that of a white woman living in the most least deprived area. And various different rates for different ethnicities that you can see there. And if we look at where we are living and working, not everyone on the call, but in terms of the work that we've done, Manchester's pretty unhealthy. Health of Manchester people are worse than England average across a range of outcome measures, and it's the 6th most deprived local authority in the country. There's a lot of children living in poverty. There's big differences between the more and less kind of underserved areas within the city. 12% of people have 4 or more ACEs, so those adverse childhood experiences which can have lasting impact into adult life. And lots of issues around housing, poverty, discrimination. And so these women are living in this area, and these are women that we're caring for, living kind of in this context. You can see that top right-hand picture is now a little bit old, but it will be mostly the same now. But in 2019, 43.3% of the population in that geographical footprint were in the most deprived decile. And so in terms of our local data, this is some data that Professor Jenny Myers has collected, one of our very brilliant academic obstetricians, who's looked at our particular outcomes, one of which is spontaneous preterm labour. So there's a lot of morbidity and mortality associated with having your baby early, which has showed quite clearly that women from certain ethnic groups have vastly different rates of preterm birth than other groups. So most notably Asian Bangladeshi women, Black Caribbean women. And Jenny's kind of split those deciles up into 4, which is a little bit hard to get your head around, but in terms of deprivation, we can see some differences there. And so the least deprived women that we care for are less likely to have perinatal death, a spontaneous preterm birth, or a baby that's small, so FGR is fetal growth restriction. But Black African women, we've found that they are less likely to have a spontaneous preterm birth, but Black Caribbean women are 1.5 times more likely, and Asian Bangladeshi women 1.7 times more likely to have a preterm birth and 1.5 times more likely to have a small baby. as a Asian Indian woman. So that's just some of the kind of context for the care that we're providing in Manchester. We, across the 3 maternity sites, care for about 18,000 women a year, which is 50% of the all the women in our local maternity system. So Kim and I wanted to understand a bit more about the experiences of our women living in those areas. We had all these national reports and lots of very poor negative experiences, and we wanted to really understand the experiences that our women were having and see what was good and bad about their experiences, and with a view to being able to influence some of the clinical care that we were providing. So we undertook an anonymous online survey, and we targeted particular postcodes, looked at the census data and targeted those particular areas that were from the indices of multiple deprivation 1 to 3, so the most deprived kind of areas within our geographical footprint. And we recruited women from postnatal clinics on the wards. We put flyers up in lots of areas within the community. We used some interpreters for some completion of the survey. And this is a challenge, I think, in doing research in this area, is really making sure that you're getting to the woman that we really need to. And some people call them harder to reach, and they aren't harder to reach. It's just that we're not getting to them and doing it in the right way. And so we had 361 women in this survey, and 74% of that sample identified as being from an ethnic minority group. Took a long time to get this published. It's only been published this year, and we did it about 3 years ago, but that's the way with research sometimes. It was a bit of a tricky paper to write. So we did this anonymous survey, and we had some free text responses in the survey as well. And we used a tool called the Experiences of Maternity Care tool, which was like art questions about people's care. And that was a tool that we used, and also some free text. And what we found reflected some of the literature, that women who were Black, African, Caribbean tended to book later, so after 12 weeks. Ideally, we'd like women to book, as early as possible in pregnancy, at least sort of 9-10 weeks. But we did find that Black, African, Caribbean, Black, British women did book later. And in terms of we gave women a score, and then we grouped women into these ethnic groups, which is a bit of a limitation of this, is that not everybody within these groups are the same. Black African women might have very different experiences from Black Caribbean women, but this was one way of us starting to try and have a look at different experiences for different groups. And mostly the scores that women reported for their care and pregnancy during the labour and afterwards were broadly similar, aside from multiparous women having reporting better postnatal scores, which does kind of make sense. If you've had a baby before, things are probably a bit easier. But also, interestingly, women who had been living in the UK for less than a year reported higher scores for their pregnancy antenatal care than women who'd been in the country for 1 to 5 years, or 6 to 10 years, or over 10 years, which is an interesting finding, I think. We looked at all of the free text comments and whether they were positive, negative, or mixed, and looked at that within the different ethnic groups. There was some small differences there, which we pulled out within the paper. And then we looked at some of the free text comments. So there were a mixture of positive, negative, and mixed comments. which was really great to kind of contextualize that quantitative work that we'd done. And that's the nice thing about doing mixed methods, is that you're able to present different types of data that kind of help to give context to each other. And so what came out from this was obviously the different booking rates. Continuity of carer really came out in the data, that women really appreciated having continuity of care, particularly in the antenatal period. The vast majority of women reported that they didn't mind being cared for by a midwife they didn't know in labour, which kind of goes against some of our literature we have around continuity of care. But antenatal continuity came out very strongly as being a want for women. There were some issues with pain relief and women not receiving pain relief that they wanted or needed, and themes around listening to women and or not listening to women at all. So we've used some of this work to do some focused work within the organisation around some of these areas, but also recognise that grouping women into these big groups is not ideal, and really the next phase is focusing on individual groups and individual challenges, such as looking at that data around preterm birth and perhaps focusing on, for example, Bangladeshi women, and doing some more work around recognising the signs of preterm labour and making sure that, you know, we're really focused on that group. So that was that piece of work that took a while, actually, and obviously I'm not full-time in research. I've got all the other clinical work going on, but very grateful to have a midwife working alongside me. And that's the next piece of work that I wanted to talk about, where Bethan, who works with me, has really kind of led this and did a lot of the work around this piece of work, which was really really nice thing to be involved with people from other organisations. So that's the great thing about when you do start to be in the post-doctoral area. You doing a PhD is quite lonely, I think, because you're just by yourself with your supervisors. But when you start to be able to work collaboratively with other people, more experienced than you, less experienced than you, from different organisations, with different skills as well, is really great, and really where research comes into itself, I think. And this has just been published as well, and this is an evaluation of a co-designed digital animation, which we call Daisy, sharing messages around modifiable behaviours to reduce the risk of stillbirth. And Mel Cooper, who was involved, and Thomasina had already done some small animations around sepsis and around gestational diabetes. And this was one that I was involved at from the beginning in terms of co-development around reducing the risk of stillbirth, which we know from that previous slide is it's higher for certain ethnic groups. So the animation was co-designed. It's about that they all slightly differ, whether it's English, Urdu or Arabic. So we got them translated into those two other languages, which are the most common other languages that we have in Manchester. And it's a between 3 and 4 minutes short animation that's culturally sensitive and runs through some of these things that you can do to help keep you safe in pregnancy. And it's a small study, but hopefully we will be able to roll this out and evaluate it more widely. But we recruited 30 minority ethnic women who spoke English, Urdu or Arabic. And the beginning, we asked them questions about their knowledge of stillbirth and healthy behaviours to reduce the risk of stillbirth. And then we gave them access to the animation. We sent it to them on WhatsApp, which proved to be a really good way to be able to send messages out. most people use WhatsApp, don't they? And the findings that was shown to be really useful. So we gave them access to this animation at between 16 and 20 weeks, and then between 24 and 28 weeks, we repeated the knowledge questionnaire about what they knew about how to keep themselves healthy and safe. And then we also asked them some questions about how they found watching the animation. Did they feel it related to them? Did they show anybody else? And, if they'd taken on any of the messages. So it was a really diverse group of women. Most women spoke more than one language, and we did use, Bethan used interpreters for a number of women within this sample. And then these are the different scores. So the blue is the first interview we did before we gave them the animation, and the green is the second interview we did. And the biggest difference we saw between those two interviews were around fetal movements, that women demonstrated that if they were worried, they should attend the maternity unit if they were worried about fetal movements. A big change around vaccinations. Women didn't really know a lot about vaccinations at that first interview, and about sleeping on your side. Now, obviously, this isn't cause and effect and giving this animation, because women will receive lots of other information between 16 and 20 weeks and 24 and 28 weeks. But the other the interviews that we did showed that they really did listen to these messages and found it a really good way to receive information. This was just the individual woman demonstrating the score that we gave them on the first interview and the score we gave them on the second interview in terms of what they knew, which showed a big change. But the real benefit of this, again, it's mixed methods, so really brilliant to have some qualitative data to give context and support what you found in your quantitative piece of work. And the woman really liked the animation. Receiving it on WhatsApp allowed them to share it easily. They could just go onto their phone and get it really quickly, rather than going through a website or some other way. And they found that the messages were easy to follow. And they watched it multiple times. They watched it with their partner. And it was a vehicle for asking questions when they came in for another appointment. And although it was a sensitive topic, women really valued the opportunity to kind of talk about stillbirth. In other languages, stillbirth isn't particularly a word. And so we really picked up on increasing women's health literacy by watching this animation, but also watching it in another language really helped understanding some of the English terms that women might be having to understand and deal with within a maternity setting. And obviously, because it was coming from the NHS and a trusted, valuable source, they really relied on it and shared it. And this is just actually the bit about health literacy and watching it in different languages and having increasing vocabulary around words such as stillbirth. Interestingly, the women weren't particularly bothered that the little characters were, had a headscarf on. They weren't really particularly noticed that. They didn't mind. They were just wanting to really focus on the messaging and not what the person was wearing or how they looked, which was interesting. So this again was recruiting women from different ethnicities, some of whom didn't speak English. There's some challenges in that, and Bethan had a pretty challenging time sometimes, I think, with phone interpreters and people, and we see this in clinical practice, losing the call, and interpreters being out in the car, and all sorts of challenges around that. But it's a good reflection on how sometimes challenging it is to do research in this area. But really positive, and hopefully we're going to roll this out wider and do some more evaluation on it, but also that this is a really good vehicle for getting information out. I think women and birthing people and families are using TikTok, Instagram, that kind of thing. You know, gone are the days of being handed a whole, 100-page book when you're pregnant. We're getting information in a different way now, and so we need to keep up with that and think about the best ways of increasing women's knowledge and education around some really important areas of health. So the next little piece of work I wanted to talk about, just check time, I better not be too long, is looking
Sorry, Kylie, I was just going to jump in. We're on
Yeah.
time, so people
fine.
will start dropping off just now.
Okay, that's fine. I'll just mention this one last piece of work that we're doing around looking at jaundice screening in the community. Another big multi-center piece of work, because we understand that diagnosing jaundice for babies with darker skin is sometimes more challenging. That's ongoing, so I've not got anything more to report about that. So I'll just skip through my other slides. I think I've got this wrong because I thought we're finishing at 12. Oh, it won't move forward anyway. I'll just move forward to just some short reflections on what it's like in the postdoc world. That it's great, but the juggle is real from clinical and academic parts of the role. It's hard to separate those out fully, I find, and sometimes I do well and sometimes I don't. And finishing a PhD is really only the start of the journey. There's lots and lots and lots and lots of learning that I've done in the last few years. And that this area is really challenging to be researching in, but it's really rewarding. And I'm thinking about the next step really, and where some of this work goes. Oh yes, so this is what I'd like my life to look like, my work life. But actually it looks like this most of the time. But a lot of the time it feels like this. And that's me out walking. That's it. Thank you very much, Jude.
Great, thank you so much, Kylie. So as I just said, I'll just share our kind of closing slide, and thank you everyone for joining. I'm aware we're at time, so some of you will need to go. If you do have any questions, though, I've just got a couple for Kylie, and if you want to pose anything to Kylie, please pop it in the chat, or you can put your hand up and unmute. That's equally good. So yeah, thank you so much, Kylie. It was amazing to hear about all you've done, and I live in Manchester too, and so I suppose I could relate to so much of what you were sharing. What I was wondering is what are some of the challenges that you faced that you think are common to midwives stepping into research?
Really good question. I think midwifery is quite small, and so it's sort of it's small, and that's a challenge in some ways, but also a benefit in other ways, because often people will know people, and so to be able to make those links and contacts is sometimes not so hard. But I think challenges are, midwifery is small, and so sometimes it's hard to kind of get your work out there or your voice out there because it's a small profession. But I think we need more nurses and midwives doing research. So it can be challenging, but just keep going because there's real benefits in it.
No, I absolutely agree, and I can see that the work that you've done is such a great example for any of us who are clinicians trying to step into research. What I know that from doing the work I do in terms of capacity building is that we have a lot of midwives, nurses, other healthcare professionals who are interested in research but are really taking those first steps or want to take the first steps and don't know how. What advice would you give to a midwife who has come to this talk, maybe here on the call, and is thinking, oh, that sounds amazing, but I am off in a trust, maybe somewhere far away, more rural, or maybe I am in a big trust, but I don't feel like I have the right connections. What are some of the things that they can do to make those first steps into a research career?
So I think look for opportunities that are out there. Sign yourself up to mailing lists of any kind of research networks that are in your area. Access your research and innovation department within your trust, because they will often know, be able to provide you direct support or signpost you to where you might need to go. I think reach out to people that are doing it. So, I'm really happy to have conversations with people wherever they are up and down the country about, steps that you could take, and start small. If you're not sure that this is for you, there's lots of internship opportunities or small little research placements that you could get to start your journey.
And then maybe my last question, the why. So I think a lot of people think, oh, it sounds interesting, it sounds all right, it sounds really hard. Why? Like, what are the benefits for the professional themselves in kind of embarking on this challenging journey of research?
I think it's knowing that you've got the potential to make a difference. And, it sounds a bit trite, doesn't it? But I really think that when you're doing research that really matters to the woman, patients, whoever that you're caring for, that's really relevant to the clinical work that you're involved in, then you are going to be making a difference to people and to coming in the future to that space and having care. And that's the thing for me, that if you can feel like you're making a difference in even a small way, then that's huge, isn't it?
No, absolutely. I completely agree. Great. Well, thank you again, Kylie. That was awesome. And
sorry for running over.
No worries. And yeah, no, thank you so much. And thank you everyone for joining. It was great to have you all here.
Thanks, everyone.